Good morning, everyone. In the sake of time, I want to say toe walking, what to do, send to me. I'm the only pediatric physiatrist around, so I can be completely just send to me. Okay, so just want to quickly go over what we want to talk about. Really, when I was talking about how I'd want to put this lecture together, this is a conversation I have with parents at least once a week, if not twice. So I just kind of wanted to give you my spiel of what I talk to the parents about, recognizing the different types of toe walking, and then really just kind of knowing which direction to possibly refer. And again, when in doubt, refer to me. Okay, so the history is the biggest part. We always talk about that, right? The big questions I always like to think about is how old is the child? This has to do with how long have they been toe walking. If this is a 12-month-old, neurologically looks normal, you've had a perfectly normal birth, development, and history, and they've just started to begin walking and they're tippy-toeing, this is much less of a concern than a 3-4-year-old who's persistent and has continued to toe walk. How old were they when they started to walk? That gives us some information about their overall strength, any other issues that could be going on with them. Are they an early walker, a delayed walker? Is the toe walking getting better or worse or the same? Again, kind of going back to that typical kids are learning to walk and move. A lot of kids toe walk when they're learning to walk, and if the parents are like, yeah, they're like 2 years old, they were tippy-toeing a lot when they were a year old, as time's been going on, it's slowly getting better, that definitely changes the course than a child who's always been toe walking and it's been staying the same, if not progressing. Or if they had never been toe walking and it's progressively happening, we'll talk about that. Can they keep up with their peers? It's really hard, obviously, 1, 2, 3, 4-year-olds to be like manual muscle testing, bend this, stretch that. So a nice kind of overall is just asking the parents when they're out and about running around with their friends, when they're in school, when they're in daycare, are they having trouble keeping up with their friends? Are they running around like maniacs despite being on their tippy toes? It, again, gives you a feel for strength, coordination, a lot of other things. And do they complain of pain? This just kind of goes in general with anything with their feet, if it's not a major structural thing like a foot deformity, but we see a lot of this, right? The flat foot, the toe walker, all this other stuff. If they're not in pain and they're really, really little, a lot of times you can just give them time. Physical exam, the things that I'm always looking at is the range of motion. Is this a fixed contracture? Are we stuck in toe walking, or do they have the range? Strength, because again, when we go into the different reasons why kids toe walk, Gowers, as you can kind of guess, there's a bit of this that can absolutely have to do with neuromuscular reasons. Their tone, so are they stiff, are they loose, are they spastic? Reasons that a child can toe walk. Reflexes and clonus, again, looking into that. I always look at their spine. I want to think, neuromuscularly, is there something going on from the brain, the spine, the nerve, the muscles, the joints? So looking for sacral dimples. The classic toe walker that progresses, like a muscular dystrophy, we're thinking about calf hypertrophies, pseudohypertrophies. Kids who toe walk for a long time, who have nothing to do with neuromuscular reasons, who are just a habit, they often have calf hypertrophy because they've just used that muscle so much. So one doesn't always mean the other. And then obviously watching them walk and looking at their gait. Simple things I do, kids like to run and move around. Usually if they have good strength, I watch them in the room, because if you've seen this a lot, the parents might bring them into you and say, oh my gosh, my kid's a toe walker. A 4 or 5-year-old who knows what they're there for will a lot of times stand there perfectly fine and walk up and down the hallway perfectly flat, and the parent is mortified. And they're like, you think I'm crazy? You don't know I brought my kid in today. So we do a lot of, if anybody's in the hallways with me at work, I walk up and down the hall, we play games, I'm asking them what they do in school, we recite the alphabet, I ask them their favorite color to name the animals on the wall. You kind of have to distract them a lot of time to really see what their gait and their walking looks like. But if they can stand flat and they can walk flat with cueing, that's really going to take you down a different road than a child who, no matter what you're saying to them, is tippy-toeing, can't stand flat, can't walk flat. And then symmetry, if it's on both feet, that's definitely something to consider versus an asymmetric toe walk, meaning one foot more than the other. We talked about the hip earlier. You can also think about that with spasticity. Posturing of the arms, this is probably the most common one I see that gets overlooked. From a primary care to coming to me for just a funny walking. A child with really, really mild hemi-CP is often an on-time walker, an on-time mover. You have them in your office throughout the exam. They're sitting on an exam table, and you don't really look at that. The parent mentions, oh, they walk a little bit funny. If I let them loose down the hallway, you'll watch one arm pop up and just the tiniest bit of toe walking sometimes. It could be super duper mild, but that's a really interesting cue in just to look for that even though we're looking at feet and toe walking, it could be affecting other things. So causes, this is really just kind of the spiel that I give the parents. After I do the history and physical, that doesn't take very long. Parents are very worried about this. especially if it's just a habit. I'm like, oh, it's just a habit, you need braces. That's not really satisfactory to the family. So to kind of make them feel that I know what I'm doing, I kind of go over all these reasons, and then I tell them which category their child fits into. So that's what we'll do today. Really, a child who's 2 and under with a normal history and a normal exam otherwise and can stand and walk flat, doesn't have any contracture, almost all the time I'm just going to say watch and wait. A lot of kids like to toe walk. They're very little people, and there's a very high world out there. They're on their tippy toes, they're looking up at counters, they like the feeling of it, they're getting their balance. A lot of times I'll tell parents, if it's like a 15, 16-month-old, come back and see me a little after 2 if you still have problems, and then we'll look into it. Is it developing into more of a habit? But under 2, I usually just tell them watch and wait. Parents ask me about certain shoes should they wear. I like kids to be barefoot, run around, and play in their environment. If they're going outside and they're doing it a lot, you can try a stiffer high top, but no bracing, no orthotics, and an otherwise completely normal exam and history. If they're older than 2, this is how I break it down in my head. So really when I'm seeing a new toe walker, I'm thinking to myself, am I missing something like a central brain spine reason, a neuromuscular reason, or sensory related, or is this more of a habit, or were they born with a contracture? And that's kind of what I'm going with. So congenital, this is restricted range of motion at the ankle. These children are born with it, so now we're kind of getting more to the stuff we talked about, like club feet, and just other congenital contractures. They have an otherwise normal exam if it's not syndromic or otherwise related. They've started on their toes. They're always on their toes. They cannot stand flat or come down. This is, to me, orthopedic that I would send serial casting, surgical lengthening if necessary. Usually could be picked up even before, taught walking age as you're just ranging the child. To really get into that, now my kids started walking and we noticed they're on their tippy toes. These are kind of the other categories I think about. So habit, this is probably the most common thing that comes into my office. They usually can stand flat. I do have one family, it's a very strong family history, and the youngest of the 3 was so tight, he actually couldn't stand flat. Even under sedation, I had to sedate him for a reason. He had like almost a 45-degree contracture, but was flat when he was younger. He was actually just a really severe case of it. They usually respond to verbal cueing. So this is the kid, you come in, 3 or 4, the parents say, oh, we noticed it, we watched it, we tell them to walk flat. When they're paying attention, like here in the office with me, they are standing flat. May have a family history of toe walking. Again, I do see this commonly among siblings, or mom or dad was a toe walker. Otherwise, a normal exam, meaning, again, nerve, muscle, joint, they've got good strength, they've got normal reflexes, there's no other concerns going on. And treatment, if they're able to achieve neutral, we definitely start with bracing. What kind of bracing do we do? I have kind of the 3 listed from top to bottom, most freeing or least restrictive, all the way to the one that's usually the biggest sell for my families. The top picture is just a night splint, and I've been really surprised lately about how many of my kids, if they're a habit toe walker who can stand flat and has decent range, I'll put them in a night splint just to hold their feet up at 90 degrees. I tell them to do that for a couple of months and come back and see me, and a good portion of my kids with a lot of verbal cueing during the day are responding to that. The middle brace is something that came out a few years ago. It's called a toe walking SMO, supramalleolar orthotic. And the idea of this is that when you're in this, just as they try to come up on their tippy toes, that high plastic in the back makes it difficult. If you've got a kid who's like a ballerina tippy toer, this isn't going to hold them, but it is a good option. The bottom picture is that traditional AFO brace. It's probably the most common way I treat toe walking. It's annoying, it's a big high plastic brace, but at 90 degrees it stops them from coming up on their toes, but they can bring their foot up and to dorsiflexion as much as they want and are able to. The idea is that they wear these as much and as consistently as possible, breaking the habit, because you really can't walk around behind your kids saying flat feet, flat feet, flat feet all day long. If you're unable to achieve neutral, this is when we go into other options. Serial casting is an option to gradually bring them up. I do a lot of Botox or botulinum toxin injections, Botox or Dysport, and the nice thing with that is sometimes kids don't tolerate the braces because it's uncomfortable, so if they have a hard time walking flat and standing flat, this helps stretch them out. Physical therapy, I put a question mark for. Habitual toe walker who you can get into a brace, there's not really much more they're going to do in therapy if there's nothing else going on. It's not going to hurt, but it's not always necessary. Sensory, the big thing here is autism, right? Autistic kids like to toe walk. These are the ones I commonly see. I put in braces. But just something to consider, lots of other kids toe walk who have, they're like, our quirky kids. They're not autistic. They just like that input and that information. So they kind of blur into the habitual. I treat them very similarly. But these kids, I would add in occupational therapy if they're not already receiving it. If they're not autistic, it's helpful from a sensory standpoint, just to kind of evaluate, see kind of what sets them off and triggers them a little bit. And sometimes you can help them overall with their kind of overstimulation sensory environment. The central causes, obviously I'm looking for a kid who is either an undiagnosed cerebral palsy or a spina bifida tethered cord situation. So looking for all those increased reflexes, increased tone reasons. And then these kids are going to be treated very differently. These are kids that are going to probably be long-term patients. Bracing isn't just going to be for 6 months or a year until they break the habit. We're going to be doing a lot of monitoring skeletally and spasticity management, possible orthopedic or surgical procedures. Neuromuscular, this is where I'm going to spend my last 2 minutes because I am trying to help speed everything up for everyone. Neuromuscular is the one that I just try to say, like, let's take a minute and think about. If you have a child who was walking normally or maybe was like a slow walker, a little uncoordinated, always been a little looser kind of kid, they started walking and then parents noticed gradually toe walking has started, so this is different than all those other ones. Bells and whistles and alarms, let them go off into your head. And I have picked up these kids who come to me, and it's, you know, it's just hard. A parent comes in and say, oh, they're toe walking, great, you know, go see ortho or go see me and whatever. And then when you get the history, it's like, oh no, they used to not toe walk. I'm like, well, what happened? Well, it's getting worse. They're doing it more. So they normally have normal flat feet, but they may be on time or delayed in their walking depending on their strength. They usually then slowly start to have increased difficulty in walking, trouble keeping up with their peers. That's where that question comes in. These are going to be the low tone, might have calf pseudohypertrophy. They have that Gower sign coming up. So I've got that nice picture of Gowers where, you know, they're on the ground and they're crawling up their bodies. And this is a neuromuscular thought. So the typical one that we think about is our Duchenne's boys, but really it can be across. I have a myotubular myopathy. I have 2 kids with that that was almost the presentation in the daughter. And then the baby was in the car seat, and I said, get the baby out. We sent them both to Dr. Duskier, and they both got diagnosed. I like this picture of the progressive showing in the changes because it explains, in my eyes, why they toe walk, because that's something I don't know if we always think about. The reason why they're toe walking is to balance. They need their center of gravity back. As they've gotten progressively weaker, especially in the proximal muscles around the hips, they want to bend and flex forward. So the way they're compensating for it without realizing it is they're thrusting their pelvis and hip forward, and they're leaning forward. They're throwing their shoulders back, as you can see in the last picture. And kind of the toes come along as just a counterbalance. They're just trying to stay upright. The important part about these kids, once we are identifying them, when I'm seeing them or ortho, is that we don't overgo on trying to keep them flat when they're walking. These are the kids that we want to stretch and we want to range and we want a night splint. I do a lot of times try offering a daytime brace to them, but a lot of times because they need to be on their toes to balance and walk, we abandon daytime bracing pretty quickly. We let them toe walk during the day. We stretch them out at night. So it's really kind of the opposite of all the other reasons for toe walking. And the important reason for that is walking is better than not walking. So flat walking would be great, but if you need to be on your toes to walk, to prolong the amount of time you're walking because of your progressive neuromuscular disorder, preventing worsening of scoliosis, things like that. The last thing I just put on there in Duchenne's and autism is a mixed picture. Because dystrophin's in the brain and you're losing that with muscular dystrophy, there is a decent population of Duchenne's muscular dystrophy boys who also are autistic. And I have a couple of kids right now who are Duchenne's, are autistic, or have just a lot of sensory issues. So I actually have them in braces during the day, and every time they come in, it's a much longer conversation. It's like, are they tippy-toeing because of sensory? Are they tippy-toeing because of the muscular dystrophy and they're getting weaker? And it's a lot of parent education about as they're going to progressively weaken, we might need to take the brace away. So it's a little bit of a different story, and it's interesting. And that is toe walking in a nutshell. And anybody who knows me knows I'm obsessed with my son, so...